Namaste. My name is Dr. Anjali Shetty, neurophysiotherapist. Welcome to part 2 of Assessment of Higher Mental Function. For those of you who have missed part 1, go back and have a look and shower your love and feedback in the comment section. In the last video, we saw what is HMF, why is it done first, how information can be picked up right from history taking. And we understood two of the components of HMF that were the consciousness and orientation. In consciousness, we understood what it is, what are the different types, the generally used scale, and its basic physiology. In orientation, we understood about how a person is oriented to time, place, and person. In today's video, we will understand some more of these components of the HMF, namely your attention, memory, calculation, insight and judgment, abstract thinking, mood and behavior. So, here we go.
So once we have assessed that the patient is conscious and oriented, the next thing that we assess whether they are attentive. So what is attention? For example, you're watching this video, you're hearing my sound, and at the same time you have 10 different background sound around you, 10 people walking around you, but you're still able to focus on what I am saying. So that is your selective awareness and response to stimuli or task without being distracted. So that's your attention. There are different types of attention, namely the selective, sustained, alternating and divided attention. And why as physios we must know them? Because this definitely has an effect on our plan of care and plan of evaluation. So some patients may be good in selective but not be good in divided attention. So basically we must know what we have to train and how we have to train. Okay. Now your first is selective attention. That is basically patient's ability to screen in relevant information and screen out irrelevant information. Okay. Some simple tests that we use to assess attention are the A hands up test and digit span test. A hands up is like there are set of alphabets, and whenever they hear the alphabet A, they would raise or clap their hands. You can similarly do it with numbers as well. The digit span test, you give them 3-digit, 5-digit, 7-digit number, ask them to repeat forward and backwards. In normal scenario, a person can say 7 forward, and for backwards there is plus or minus 2, so 5 backwards is considered normal. The next is sustained attention. So basically we check how long can a person maintain his attention during a conversation or a task. So this can be very well picked up during history taking. So while he's giving you history, in between suddenly he's just scratching his leg, looking outside the window, looking at the other side, So you have to note down the time that they can maintain during a task. Next is alternating attention. So basically that's your ability to go back and forth of two different tasks. So here we give them two different tasks, say for example, 2 addition, then 2 subtraction, again 2 addition, 2 subtraction. So going back and forth of two different tasks, and we note down how well they can do it. The next is divided attention. So that's basically your dual tasking or multitasking. Okay, man is supposed to do dual or multitask. Correct. So simple test like walkie-talkie test. So while you walk with the patient, have general conversation or ask them questions. So we basically see how they are able to walk as well as talk. That's your walkie-talkie test. So some other tests that we use for assessing attention are the line cancellation test. So basically in line cancellation, there are vertical and horizontal line. You ask them to cancel them in between. So this is also a good test for perceptual disorder. Some people with like hemi-neglect may not cancel one half of the paper. Or you can also assess them by putting simply a dot on the center of the paper and ask them to bisect as many number of lines. So if a person has hemi-neglect, will only draw lines in one half of the paper. 3-step task on the other hand is a task where any task that has 3-step process to it. Say for example, you give them a paper, ask them to divide it into half and then another half. Basically what you are seeing here is how long can they maintain their attention in that task and their ability to follow through the instruction. Inattention could be because of toxic metabolic encephalopathy, could be because of increased intracranial pressure, especially seen in a traumatic brain injury patient, if there is a frontal lobe lesion, if there is a posterior non-dominant hemisphere lesion. Right? Now there are some good to know points. Now we said the non-dominant hemisphere is responsible for attention. Right? So we all know that the right hemisphere controls the left side and the left hemisphere controls the right side. Okay. Now most of us are righty. So our left side is the dominant and the right side is the non-dominant hemisphere. Okay. So keeping in mind the right side being non-dominant, let me tell you, so that would control both your right and left side ka attention. Whereas your left side is only responsible for the right side ka attention. Now clinically how this is relevant. For example, you had a non-dominant right side lesion, hemisphere lesion, you would see a left-sided hemi-neglect or hemi-inattention or sometimes both. But if the left hemisphere is affected, that is your dominant hemisphere, you may not see an hemi-neglect. And why so? Because the left controls only the right side, but the right also controls the right side. So that's how it gets compensated. Hence, you do not see a hemi-neglect with a dominant hemisphere lesion. So the next very interesting part of HMF is the assessment of memory. इस पर मैं थोड़ा ज़्यादा टाइम लूँगी ताकि सारे concepts clear हो जाए. So what is memory? Memory is a process where you register, retain, recall and retrieve past experience, knowledge or ideas. So आप कोई event या कोई बात अपने दिमाग में रजिस्टर करते हो, उसे रिटेन करते हो और जब चाहे उसे याद कर सकते हो. कोई भी आपके आइडिया या पास्ट एक्सपीरियंस को, उसे हम मेमोरी कहते हैं. Based on types, it's of two types, declarative and non-declarative memory. Declarative memory is also called explicit memory, wherein you consciously recall explicit events or facts. Okay? यहाँ आप consciously याद करते हो. So your event wala memory is called as episodic memory and your facts memory is called as semantic memory. Episodic memory, as the name suggests, is remembering an event or an experience or parts of an event in such a way that you can actually go back and relive that day. Okay? So for example, your 18th or your 21st birthday was very grand, you threw a grand party, you dressed up well, your friends came, you got a big cake, there was good music. You can actually remember all this and recall that entire day. Okay? Now your hippocampus is responsible for this episodic memory. So होता क्या है, आपकी ये जो म्यूज़िक आपने सुना था, खाना जो खाया था, ये सब आपके ऑल्फैक्टरी, विजुअल एरिया, ऑडिटरी एरिया में स्टोर होता है. जब आप वो इवेंट को याद करने की कोशिश करते हो तो ये सारे एरियाज में बल्ब जलने लगते हैं. So your hippocampus connects all these dots and make you recall that day as a day. So hippocampus is very very important. Now जहाँ आप एपिसोडिक मेमोरी में बातें डिटेल्स में याद रखते हो, हाउ, व्हेन, वेयर, व्हाट, semantic memory is like remembering some facts, some known meaningful facts or something to remember in gist. Okay, so these are something that you have learned over your experiences of your life. So these are the I know kind of memory. Okay, so for example, name of your city, prime minister ka naam, all of that which are some facts. Okay, and your frontal and temporal lobe is responsible for your semantic memory. So remembering the parts is important because any lesion here would have an effect on the specific memory. Now they say that there is a connection between episodic and semantic memory. I'll just quickly give you an example for this. If I ask you what is your friend's favorite color, you would immediately bounce and say blue color. Okay, blue, pink, whatever. Because you know for the fact of your 5 years, 10 years of friendship that you know for the fact it is blue color. But if I tell you, how sure are you and what makes you think it is blue color? And then you go back and remember an episode or event, like maybe you would have gone shopping with him and he must have mentioned, I like blue color, or often you see him wearing a blue t-shirt or a shirt. And so basically the event was shopping. But since you do not keep recalling it again and again, okay, but with so many years of friendship and seeing him wearing blue shirt often, now you have only remembered the gist of it. Because at times he'll be like, I know for the fact he like 99% I'm sure he's blue is his favorite color, but I can't recall where he actually told. That means episodic memory is a problem. ओके सो बातें हम हर बार सब जिस्ट डिटेल में नहीं करते जब उसको हम जिस्ट में स्टोर कर लेते हैं. ओके सो दैट्स द कनेक्शन बिटवीन दैट. नाउ टॉकिंग अबाउट द नॉन डिक्लेरेटिव और इम्प्लिसिट मेमोरी. जहाँ एक्सप्लिसिट मेमोरी में हम बातें कॉन्शियसली याद करते थे, नॉन डिक्लेरेटिव में हम अनकॉन्शियसली करते. So it's based on your previous experience or skill, something that you have learned, and now it's become so automatic that you don't actually have to recall the steps. For example, riding a bike, tying shoelace. बाबा को तुम जब सीजर देते हो, he will just start cutting the hair. Okay, maybe initially you must have learnt it in a procedural way, like how to sit on the bike first, how to keep your hands on the handle, and then pedal first and again. But now when you sit on the bike, you just start cycling, right? You don't actually have to think of the steps. So that's your implicit memory. Your cerebellum, putamen, and caudate nucleus are responsible for implicit memory, your members of motor control. Now, another interesting here is the priming. Okay, इसको मैं एग्जाम्पल के साथ एक्सप्लेन करूँगी. So priming होता क्या है? Basically, it's an external environment trigger which makes you act in a certain way. Alright, and the example is, बहुत साल पहले आपने एक गाना सुना होगा, इट्स द टाइम टू डिस्को. उसका वो हुक स्टेप भी है. ये गाना आपने बहुत पहले देखा था, बीच बीच में भी देखा होगा. बट टुडे देयर इज सैटरडे नाइट एंड योर फ्रेंड्स डिसाइड, वन ऑफ योर फ्रेंड्स सेज, हे लेट्स गो टू डिस्को. एंड आउट ऑफ एक्साइटमेंट यू सेड, yes, come on, it's the time to disco, and you did that hook step. Alright, without even thinking about it. Alright, you could recall something which you had seen long time back. The external trigger was the word disco, and automatically your body did the same action. So that's priming. As physios, it is very important for us to know this, okay, the types of memory, because sometimes declarative memory होता है और non declarative नहीं होता है, या non declarative होता है. Okay, that will change your approach. Okay, all your ADLs, by the way, have implicit memory. Okay, now for example, a patient जिनको आप बोलते हो, ट्यूसडे हमने जो डंबल्स के साथ एक्सरसाइज किया था वो आप कीजिए. He will look at you. He may not be able to recall what you have done on Tuesday, but the minute you give him dumbbells in his hand, he will start doing the exercise. That means his implicit memory is intact, but his episodic of what happened on Tuesday is affected. Whereas a patient जिनको तुम रोज डंबल्स के साथ सेम एक्सरसाइज कराते हो, and he still asks you, madam, अब क्या करना है? I can't recall. Okay, then there is a problem in the implicit area, and then you may check out the cerebellum putamen region. Okay, now this was based on the types. Now based on time, there are three types of memory: immediate memory, short term, and long term memory. Immediate memory में you ask them to repeat after you some words or sentences immediately. For short term memory, something that happens few minutes or hours back. So you can ask him, what time did you have your breakfast? What time did the doctor come for the rounds? Something that happened few minutes or hours back. To check your immediate and short term memory, there's a small memory game that you can play. So you give them 5 unrelated words. For example, window, television, ice cream, circle, bed. Okay, some words like this, and you immediately ask them to recall the 5 words, and maybe after 5 to 10 minutes to check for short-term memory. Long-term memory, on the other hand, are some events that you try to ask them which happened few months or years back. So you may ask them their birthday, their marriage anniversary day, their school passing year, okay, something like that. Amnesia is where your memory is affected. It's a condition. So if your recent memory is affected, then it is called as anterograde amnesia, and that shows that there is some affection at the hippocampus. And if you have forgotten the past events, then that is called retrograde amnesia, which shows a thalamic lesion.
So the next part of higher mental examination is the assessment of calculation. What we are actually assessing here is their ability to do mental maths. Your dominant parietal lobe is responsible for your calculating skills, so any lesion here would have an effect. Make sure before you ask mathematical questions that they are alert, not fast asleep, otherwise you would have false reports. Now, it is also dependent on their IQ and education level. Simple tests like counting forward, backward, basic addition, subtraction, multiplication and division. Even if you are dealing with an illiterate person, you can ask them question around the rupees. For example, आपके पास 10 रुपया है, 7 रुपया का आपने एप्पल लिया, अब कितना बचा? By this, what we are actually assessing is the time that they take to do simple calculation, the amount of attempts that they take to answer. So you're assessing their thinking ability in terms of numbers. If they are totally unable to do it, it is called as acalculi, and if they find it difficult, it is called as dyscalculia. The next is abstract thinking. Before we understand abstract thinking, let's just quickly understand what concrete thinking is. So concrete thinking आप बच्चों में ज़्यादा देखोगे. For example, if they see a biscuit on the floor, they will pick it up and eat it without thinking much. If you hear your ringtone, you without thinking you know you're getting an incoming call. That is your concrete thinking. But in abstract thinking, without hearing, touching, feeling, seeing, you can actually imagine about something. So you are seeing on the screen, for example, and suddenly you get a thought, काश मेरे पास iPhone होता. For a minute, you actually thought that you had an iPhone in your phone, in your hand. You could imagine the color, the texture, the logo of iPhone in your hand. So that was your abstract thinking. Abstract thinking is also to find or know about the similarities and difference and relation between two objects. For example, you can ask the patient, what is the similarity and difference between papaya and banana? Their answer would be similarity is that both are fruits, difference is their texture, color, taste. Their ability to relate between two objects, for example, chair to table, sky to birds, is their abstract thinking. Abstract thinking is also the ability to interpret. So you give them simple proverbs that we use in a day-to-day language, like tit for tat, jaise ko taisa, and tell them, what do you understand by this? So you have to ask. If they give you meaningful proverb justification, that means their abstract thinking is intact. Insight and judgment. Insight is awareness या जानना, and judgment is what do you do. So for example, you give them a situation. If you open the door and you found a neighbor's letter, what would you do? So his insight would be that knowing that this is not my letter and it is neighbor's letter, whether he keeps it or goes and gives to the neighbor is the judgment. Insight is also awareness of their own illness. If they are completely neglecting, behaving irrational, that means they might have a lesion in their non-dominant parietal lobe. If they have insight, they know it's not theirs, but their judgment is poor, they don't know what is right and wrong, then there is a lesion in the orbitofrontal region.
It is also very important to assess the mood, behavior, appearance and depression. Most of this information we would gather during history taking, either by observing or your family members would tell you. In mood, we are actually seeing how are their spirits, whether they are behaving too hyper or too low, or their moods keep constantly changing, whether their behavior is agitated or they are cooperative. In appearance, we see how neat or unkept they are. Just by observing, we'll come to know if their buttons are up and down, or if they have shaved only one side. This would give us a lot of information if there is any neglect or apraxia.
For depression, if they're constantly low, irrespective of improvement and changes, then you would assess them on Beck Depression Index,
which is a self-scoring scale and has questions related to your emotions. So we total the answers, and if the score is between 0 to 10, it is considered normal ups and downs. If it is above 40, it is considered as extreme depression. A persistent score of 17 or above indicates that you might need treatment.
and further refer to a psychologist. Delusion, illusion, and hallucination. So, delusion is firm false beliefs which are not accepted in a society or culture. And in these patients, even if you give them evidences that the beliefs are wrong, they would not accept it. For example, a beggar who does not have any money suddenly starts feeling he is the richest person, he is Ambani, and he talks to people in that way, and his behavior would be changed thinking that he is Ambani. So that is delusion. Illusion is misinterpretation of external stimulus. For example, even if you are gently touching the patient, they would imagine that you're not touching, you're actually hitting them with the hammer. Or if they hear you singing, if they hear any sound, they will imagine that somebody is swearing at them. Hallucination is misinterpretation or expression without an external stimulus. So they would often say, I can see somebody, I can hear voices, or I can see a dolphin on the tree, which is all practically impossible. And this would give us an insight that if there is any psychiatric illness along with the neurological condition, and as we being the first person of the rehab team to actually visit the patient, we could give further referral to get a better understanding, as all of this is responsible and will have an effect on our evaluation and our further therapy approaches. Hi friends, I hope today's lecture was helpful. So we went about in understanding different components of HMF. In the third part, there is one component remaining, that is the assessment of language and speech, along with some different scales that we generally use in our practice will be discussed. So stay tuned for part 3. And if you have any queries in today's lecture, please feel free to mention it in the comment section. We would address them. If you like our today's video, don't forget to like, share and subscribe, and hit the bell icon to get future notifications from our channel. Till then, stay healthy and keep learning through Physiogyaan. Namaste.